Hi. Today we'll be discussing about solitary pulmonary nodule, which as a clinician is a very difficult area. So if you have a patient who's a smoker with a large lung mass, the evaluation is very straightforward. You just have to take a biopsy. Whereas in the case of a solitary pulmonary nodule, the patients are often incidentally picked up on a routine health checkup, or maybe the patient has only minor symptoms of cough for maybe few weeks, and a solitary pulmonary nodule is incidentally detected on an X-ray. So how far to go about in the diagnostic evaluation is always a dilemma in the clinician's mind. So hopefully we'll discuss that in the next few minutes. So the contents of this presentation are for educational purposes only, and it's not intended to be a substitute for professional medical advice, diagnosis or treatment. So solitary pulmonary nodule actually by definition lacks some things. That means there should be a single lesion in the lung parenchyma, and with that there should be an absence of lymphadenopathy, mediastinal lymphadenopathy. There should be an absence of any pleural effusion, and there should be absence of collapse of any part of the lung. So by definition it is less than 3 centimeters in diameter, although mostly the area of interest is actually the ones which are less than 1 centimeter. It is entirely surrounded by lung. An easy way to classify it is into benign and malignant. A more pragmatic definition for the clinician would be to classify it into solid, part solid or pure ground glass opacities. Solid solitary pulmonary nodules will be entirely like a brick or a stone. So it will be entirely made up of a solid component, whereas a pure ground glass opacity would be more like a cotton ball. So you can see the vessels running inside this cotton ball or inside this pure ground glass opacities. And in between these two are the part solid, subsolid pulmonary nodules. This has a component of solid part and a component of ground glass opacities. The malignancy risk is obviously highest for the solid pulmonary nodule. So how should the workup of solitary pulmonary nodule begin? The emphasis should always be on risk factors for malignancy. What we are basically trying to exclude is malignancy. So a patient with a very high pack year of smoking, a prior history of extrapulmonary malignancy, a patient who has significant weight loss, a patient who has hemoptysis or a change in the nature of cough or hoarseness of voice, these patients should have further evaluation even if the solitary nodule is smaller in size. So for example, a 24-year-old male non-smoker who got an X-ray done for dry cough found to have a solitary pulmonary nodule would be more likely to be benign than a 62-year-old female smoker who got her X-ray done for a solitary pulmonary nodule for hemoptysis. So one question. A solitary pulmonary nodule in a patient who has a head and neck cancer is more likely to be metastasis or primary lung cancer. You could pause your video and think about the answer. The answer is the malignant solitary pulmonary nodules are equally more likely to represent a primary lung cancer, so that it is unlikely to be a metastasis from the head and neck cancer than it is to become a primary lung cancer. And the exceptions to this rule are sarcoma, melanoma and testicular carcinoma, which can also present as SPNs. The metastasis from sarcoma, melanoma and testicular carcinoma can present as SPNs. Which lung diseases predispose to cancer? One of the most important lung diseases, interstitial lung disease, of which is idiopathic pulmonary fibrosis, which has a high risk of lung cancer. I usually screen my patients who have idiopathic pulmonary fibrosis at least once in a year for the development of lung cancer. Many societies even recommend low-dose CT for following up patients who have high risk of developing lung malignancy, especially in association with these conditions, scleroderma and asbestosis. So the radiographic characteristics, especially of HRCT, would be it should be at least 1.5 millimeter thin section. 1 millimeter would be great, but at least less than 1.5 millimeter thin section, and both lung window and the mediastinal window has to be seen. On the chest X-ray, the things to be noted are the nodule size. Obviously, the larger the size of the nodule, the more likely it is to be malignant. The shape, whether it is irregular in shape, it is obviously more likely to be malignant. The solitary pulmonary nodules which are centrally located are more likely to be small cell carcinomas, whereas the ones which are subpleural, peripheral, and in the lower lobes are more likely to be metastatic malignancies or even adenocarcinomas. Calcifications will be discussed in detail later. So we'll come to a case. A 51-year-old smoker came with history of chest pain, hemoptysis. His examination yielded nothing. On inquiry, the patient had similar complaints 3 months back. Also, patient was investigated with an X-ray which showed a solitary pulmonary nodule in the right mid-zone measuring 2 centimeters in diameter. We got another X-ray now which shows similar lesion with diameter of 2.6 centimeters. What is the inference? So a lesion which increases from 2 to 2.6 centimeter does not actually make a big difference on an X-ray or even a CT scan, but the lesion actually has doubled in its volume in the last 3 months. So how will doubling time help you in identifying the character of the lesion? So the volume of this lesion increases by 4 by 3 pi r cube. So a small increase in radius will increase the volume very much, especially when you see an X-ray in a two-dimensional view. When old radiographs are available, growth rate and nodule doubling time can be estimated. So what you basically need to know is all malignant tumors usually have a doubling time of 20 days to 400 days. So if the doubling time is less than 20 days, it is more likely to be an infectious cause. The lesion is rapidly progressing in size. And if it is more than 400 days, it is more likely to be benign lesion. So we already saw that the difference in sizes is very minimal and it's very difficult to pick up by the naked eye. So a solid solitary pulmonary nodule which is stable in volume over a 2 years period can be reliably considered benign. The exception, if you had noticed in the previous table, the exception is actually adenocarcinoma, which can be very, very slow growing. So some benign lesions which we might neglect based on this principle might turn out to be adenocarcinoma. So that is a word of caution. Some lesions which present like solitary pulmonary nodules, one is this. There is a peripheral pleural based lesion which is small, and there is an involution of the underlying lung also with prominent bronchovascular markings and vascular markings. This is usually the case in a patient who had his empyema drained or a pleural effusion tapped previously, and this is called a rounded atelectasis. This looks like a solitary pulmonary nodule on chest X-ray. So CT scan versus X-ray. CT scan has the edge over X-ray because it can also diagnose mediastinal lymphadenopathy. A nodule which is not clearly seen on X-ray could be seen clearly on CT scan. And also CT scan detects spread to the lymph nodes and demonstrates chest wall involvement. Although spread to the lymph nodes by definition of a solitary pulmonary nodule excludes it from being a solitary pulmonary nodule, but CT scan is more sensitive in picking up even small lymph node enlargements. What are the CT characteristics which make a solitary pulmonary nodule more likely to be benign? Margins of a benign nodule are usually well circumscribed. They are rounded in appearance. There is no pleural tag or notch. And the calcification patterns are usually central stippled laminar calcification pattern. So this is a Wriggler's notch. There is a notch in the lung lesion of the solitary pulmonary nodule, and this is called the Wriggler's notch, and it is suggestive of a malignancy. The margins, when it is regular and rounded, is less likely to be malignancy, and as it becomes more spiculated, the chances of the solitary pulmonary nodule being a malignancy are high. So this is probably a benign lesion, whereas this, where the lesion is in the center of the parenchyma, but there are some lesions which extend to the pleura, which is called the pleural tail. This is highly suggestive of malignancy, and these lesions, even if the lesion is very small, should be evaluated further. This lesion also, you can see that the margins are not actually regular. There is a speculation in the margins, which is more likely seen in malignancy. So this lesion with a center which has a dense center and a periphery which is less dense. The periphery has more ground glassing. You can see the vessels underlying these areas, and the center is very thick. So this sign is called the CT halo sign. It is more likely seen especially in invasive aspergillosis. We had a patient 2 years back who was very sick, admitted to the ICU. We didn't have a diagnosis at all. She had bilateral infiltrates. She had uncontrolled diabetes also. A CT showed this. We started her on caspofungin for possibility of aspergillosis. The response was very nice. The patient actually improved. Patient had to be put on ventilator, but after caspofungin was initiated, the patient improved, and ultimately the endotracheal tube culture also came as Aspergillus fumigatus. So this is one sign which actually helps the patient, especially in starting an antifungal even prior to any culture reports or a gram stain report. The other conditions where this halo sign is seen is, one is Wegener's granulomatosis, and also in some forms of angioinvasive sarcoma malignancies, where the center of this lesion, that would represent the infarcted lung lesion, and the periphery would actually represent the lipidic growth. The growth of the tumor will be seen in this ground glass opacity is the growth of this tumor. Whereas in cases like aspergillosis or Wegener's granulomatosis, this lung is entirely the infarcted lung. The center of the halo is the infarcted lung, and the periphery of the halo, this area is the hemorrhagic lesion, especially in Wegener's granulomatosis. So we talked about the differential diagnosis of CT halo sign. So this is another example of a halo sign. You can see a center and ground glass opacities over the periphery. Now, what are the patterns of calcification which makes it benign, and some make it more likely to be malignant? Mostly eccentric calcifications are highly suggestive of malignancy. Patients who have an old treated pulmonary tuberculosis and calcifications over that lesion of pulmonary tuberculosis is usually diffuse. So in this case, you can see that the calcification is diffuse and it is more likely to be a benign lesion. Here you can see target like or bullseye calcification. This also is more likely to be a benign lesion, usually histoplasmosis. Here you can obviously, the clue is there in the slide itself. You can see that there are multiple calcifications in the lung parenchyma. This is a popcorn calcification seen in hamartoma. So this is what I was telling about. The peripheral calcification, which is eccentric, makes it highly likely that this lesion is malignant. So this lesion I would say is more likely to be benign because it has rounded edges, there is no pleural tail, it is having a rounded lesion and it is calcified entirely. This lesion we had seen earlier, see if you can guess it. This is a target or bullseye calcification. We already saw the example. So here another target calcification, and this one would be a hamartoma. This is another example of a popcorn calcification. This lesion, although it is not classical, this is not a solitary pulmonary nodule. There are multiple pulmonary nodules, but I thought this CT was very informative. You can see the pulmonary vessels feeding this nodule, which makes it highly likely that these lesions are malignant. So here in this case, probably we would think about a malignancy and a metastasis to the lung, since it is multiple in number. So now let's compare these two images. One image on the left side, you can see that this is almost entirely made up of ground glass opacities. Here you can see that there are some areas of ground glass opacities, and these areas are solid opacities. So this is more likely to be malignant than this. Cavitation, especially eccentric cavitation, might be a marker of malignancy, especially small cell carcinoma. This is also a thick wall cavity which has air fluid level, but the cavity wall is very thick. So always an underlying malignancy, especially a squamous cell carcinoma, has to be ruled out. Here you can see that there is a cavity over which there is a lesion inside the cavity, which makes this air-filled space into a crescent-like shape. I'm sure most of you would have guessed the lesion. It is a fungal ball. Usually in aspergilloma of old TB cavities, you can see fungal ball. The other causes of air crescent sign, the ones which I have seen actually, would be a clot in a cyst or a cavity can cause an air crescent sign. Echinococcus can cause air crescent sign. Mucus plug in cystic bronchiectasis often presents as air crescent sign, and of course the most common would be aspergilloma. The others are just given for academic interest. So what is this? Here you can see that there is a nodule here with one nodule adjacent but separate from the primary big nodule. This is a satellite nodule. Satellite nodules usually indicate that it is a benign lesion. Although you cannot rule out a malignancy even in a satellite nodule, it is more likely to be a granulomatous infection, more likely to be tuberculosis or any infection. Also in sarcoidosis, there is a sign called galaxy sign, which would present exactly like this, exactly like a satellite nodule. Here you can see that there is a lesion which is actually having low attenuation. After the contrast is given, there is an contrast enhancement. This is actually a marker of malignancy. But what happens if after the contrast the lesion entirely becomes white or hyperdense? Then the lesion is more likely to be a vessel. So this is more likely to be an arteriovenous malformation because the contrast is entirely taken up by this vessel. In the other situation, there was just an enhancement. So in these cases, usually the enhancement would be around more than 15 Hounsfield unit, then it is more likely to be a malignant lesion, whereas this is homogeneously enhancing and this is more likely to be a vessel. So what is the role of MRI? Personally, I never use MRI for diagnosing any solitary pulmonary nodules. Maybe an experienced radiographer who can read an MRI better would be better equipped than me. But actually it is indicated mostly for Pancoast tumors and lesions over the diaphragm or pleura, although I have never used it. Next is the positron emission tomography. This is now in use, especially for solitary pulmonary nodule. Positron emission tomography is being actually overused. So the principle is an 18 FDG is injected into the patient, and the cells take up this 18 FDG in glycolysis. But the dye is bound within the cells and it cannot enter the normal glycolytic pathway. And so whichever areas in the body have increased metabolic activity, like the brain or a malignant lesion which has increased metabolic activity, would take up more of this 18 FDG. And the uptake is quantified using SUR, standardized uptake ratio. There is actually no value of standardized uptake ratio above which it is definitely malignant, although many people tell that 3 to 6 is a good cutoff, or 3 SUR is a good cutoff. Although many radiologists would tell that there is no such thing as a cutoff for an SUR. There are chances of false negative if the lesion, as we saw previously, if it is a bronchoalveolar carcinoma which is growing very, very slowly, there will be less metabolic activity in that lesion, and there is a possibility of a false negative. Also in patients who have carcinoids which are very slowly growing, the typical carcinoids will have a false negative PET scan. False positive is in infections, where especially tuberculosis is one lesion where often we see PET positivity. Also patients who have uncontrolled hyperglycemia, for obvious reasons. But the resolution is currently 7 to 8 millimeters, and the imaging of nodules which are less than 1 centimeter is actually unreliable on PET images. So on the left side you can see the PET images, and here you can see that it has been reconstructed with a CT image, which is a PET CT image. So now let's see about how to approach the case of solitary pulmonary nodule with one example. So first of all, as we previously saw, to see whether the probability of malignancy in that particular patient is high. And there are lots of guidelines on how you can predict how a patient is deemed to be high risk of the SPN being a malignancy or otherwise. So you can check on these references. Most of it is what we have already spoken about. So if you feel that the probability of a malignant disease is low and the patient has a stable serial chest X-ray over the last 2 years, or if the patient has characteristic benign calcification pattern, like we saw the hamartoma pattern of popcorn calcification, or the histoplasma pattern of bullseye target lesion, those patients who are less than 35 years of age, patients who have no other risk factors, who is a non-smoker, no loss of weight, no loss of appetite, no hemoptysis, no clubbing, no lymphadenopathy, these patients can be observed with serial CT scans depending on their size. And the patients who have a high probability of malignant diseases, who are surgical candidates, should be considered for staging followed by VATS or thoracotomy. So if the patient is highly likely to be malignant, you go ahead with a surgical removal or resection. So what are the other biopsy techniques which are less invasive than a surgical removal of the lesion? The most preferred would be bronchoscopy, although the usefulness in case of SPN has previously been very low. Although with the newer technology, especially of EBUS and fluoroscopy guided biopsies, many cases which were previously biopsied using CT guided biopsy are now amenable for endoscopic or bronchoscopic biopsy. The classical way of sampling of a solitary pulmonary nodule is percutaneous needle aspiration. That can be done under fluoroscopic or CT guidance. So peripheral lesions, especially lesions which are less than 2 centimeters, may be biopsied using a needle aspiration, which is CT guided. The contraindications are patients who have bleeding diathesis, patients who have large bullae, if the lesion is in the interior of the lung, patients who have severe pulmonary hypertension, and patients who cannot hold their breath. So surgical biopsy, as we previously saw, is the only curative procedure. After the procedure, if the lesion is malignant and there is no extrathoracic metastasis, the patient can be deemed cured. The other option is video assisted thoracoscopic surgery with the option to convert to thoracotomy. So let's see a lady who is 52-year-old who went for a health checkup. You can see that there is a lesion in the right mid-zone. There is no other collapse or lymphadenopathy or pleural effusion in this lesion, in this patient, although the left side is not seen. So the lesion we have already identified. So what is the next step we do? This patient has low risk of malignancy because the patient was identified on a routine health checkup. But does that mean that we always do nothing? So I think better to investigate further because the lesion is not very small. And first step is to confirm an intrapulmonary location. So this is another patient's CT. You can see that the lung, the SPN is near the pleura and it is regular, rounded. These lesions usually which are near the pleura, near the minor fissure, they are usually not significant. This lesion also you can see is pleural. There is a well-defined outline which is smooth and regular. So it is probably an old lesion rather than a new lesion. Here you can see in another patient that the left mid-zone has a lesion. This patient had neurofibromatosis 1 and was referred for a CT guided biopsy. But after the CT, actually what we see is that there was a neurofibroma over the chest wall. This is another patient who was referred for a CT guided biopsy. We could see that in the rib margin, we can see the rib callus. That must have been a healed fracture of the rib. So in this patient, in our lady, the lesion is confirmed to be intrapulmonary itself. The margins, I don't know, you can see that it is a bit irregular. The margins, I don't think, look very regular. So what is the next step? Is this benign or malignant? So the criteria for benign lesion is if the patient has calcification, like we said previously, absence of an eccentric calcification, absence of enhancement, and no growth in 2 years. These are criteria for benign lesions. So this is another patient who has a well-defined calcified lesion, which is more likely to be benign. Whereas this lesion, you would have already guessed, is an eccentric lesion and more likely to be malignant. This is also another patient who has a left mid-zone lesion, which over the course of 2 years has not increased in size. On a CT scan also there are calcifications. So this can probably be left alone if the patient does not have many features of malignant lesion. Here you can see that there is a pleural based lesion, but there is no enhancement post contrast. This is also pointing towards more of a benign lesion. So in our lady, we got a previous X-ray. This was the present X-ray. This is the previous X-ray in May. So even on the X-rays, there is an evident increase in the size of lesion, and we already saw the CT lesion which had a lobulated appearance. Now we'll give a contrast and see. So here you can see that post contrast, if you look carefully, there is some enhancement of this nodule. This is enhancement is usually taken after 1 to 4 minutes after giving an iodine IV. So this, in our patient, there is no evidence of a benign lesion, and hence it is of indeterminate quality. So next step would be some lesion, some way to biopsy the lesion. So what we did was we went ahead with a CT guided biopsy. Although you could argue that a bronchoscopic biopsy under fluoro guidance or a mini probe guidance would be equally good for diagnosing this patient. So during biopsy is always indicated, not an FNAC, because always the pathologist is going to ask you for more material for EGFR mutation studies. So we usually use the Bard biopsy forceps. The diagnosis in this case was an adenocarcinoma. So next step is to stage the disease. So the obvious way to stage the disease would be for a PET scan. So in lung cancer, the staging would be for the nodes, for extrathoracic metastasis, and the local staging. So this is another patient. Actually, here you can see that there is a localized lesion in the right upper lobe. There is no mediastinal lymphadenopathy here. You can see even on the PET scan here, this is the PET CT and this is the PET scan. You can see that there is a single lesion here. So that might be amenable for removal, surgical removal. Here you can see an N1 node. There is an ipsilateral mediastinal node. Here also you can see the ipsilateral mediastinal node. There is an enhancement on positron emission. Here you can see that the cervical nodes are also taking up the FDG. So coming to the end of the presentation, I want all of you to try to guess which among these would be more malignant. Although it is very difficult to differentiate, you could pause the video and see which among this would be more malignant. Here you can see that this lesion is solid. It has irregular outline and there are some pleural tails also here from the lesion. This is a definite pleural tail. These. Here it is more or less rounded, although you could argue that there is some amount of lobulation and there is a small pleural tail also. I would be more concerned about the patient on the left than about the patient on the right, although I would definitely go ahead with the evaluation of this patient too. So the fundamental idea when dealing with a solitary pulmonary nodule of more than 8 mm is to not miss a malignancy. Many of you who would already know about solitary pulmonary nodules would be thinking about how I could or why I did not mention about the Fleishner Society guidelines. That is the baseline guideline for the follow-up of any solitary pulmonary nodule. I didn't want to make this presentation more complicated by including that also. It is a very simple guideline. I'll be adding the link in the description and you should all definitely go through the Fleishner Society guidelines. The basic concept is the nodules which are less than 3 mm, whether it is a solid nodule or a ground glass opacity like nodule, can be best left alone. Those which are 3 to 6 mm could also be safely followed up in intervals of maybe 6 to 12 months depending on the solid component. And those which are more than 6 mm to 8 mm should always be evaluated aggressively. So this is the basic gist of the Fleishner guidelines. If a lesion has a definite criteria for benignity, like we said, then you can forget about it. Else the lesion should be assumed to be malignant unless proved otherwise and should be biopsied. So I hope that was a brief introduction to solitary pulmonary nodule. We've briefly covered about some of the signs, especially the halo sign, some things about the roundel atelectasis. What are the features of malignancy, like an eccentric calcification, like a pleural tail, like a spiculated margin. We have also briefly gone through how to evaluate a solitary pulmonary nodule and how to go about its management also, how to evaluate with the biopsy also. Briefly touched also upon the PET scan. I hope that was useful. Thank you.